In today's video, we are going to talk about pusher syndrome. Pusher syndrome is a condition that can occur after a stroke that affects both balance and stability and can be a limiting factor as far as overall outcomes. So in this video, we're going to go into what pusher syndrome is exactly, how you would know if you are someone who is experiencing a condition called pusher syndrome, who are the most likely to be impacted by pusher syndrome, and of course, an approach or a strategy to overcome this extremely limiting, potentially limiting barrier when it comes to walking and overall balance. In particular, if you are a caregiver who is caring for someone who has pusher syndrome, you are going to learn some absolutely essential tips and tricks to provide the most appropriate cueing for your loved one to ensure that they are not only safe, but that there's less pushing, and of course, to improve their overall independence. If you're new to this channel, I'm Tara, I'm a neurologic physical therapist, and on this channel, we talk about anything and everything related to mobility, health, fitness, and mindset in the context of neurologic injury, with the end goal of empowering you with as many tools as possible to take ownership of your rehab and your health, to live an overall more active, more mobile, pain-free, happier, healthier life. Now, before we dive into today's video, I did want to remind everyone that we do have a membership program that, among other perks, does include monthly live Q&As where you can ask your specific questions, and we meet once a month where I answer your exact questions. To learn more about that, as well as all the other perks that you will receive with your membership program, visit rehab-hq.com. But now, let's dive into pusher syndrome. So as I mentioned, pusher syndrome is a condition that does impact balance and stability. And as the name suggests, it is when someone pushes really hard, in this case, toward the weaker side of the body. So much different than the majority of the videos on this channel where I talk about compensation, where someone has a tendency to rely heavily on the uninvolved, uninjured side of the body, the strong side of the body. That's compensation. Someone will constantly lean to their stronger side as kind of a maladaptive strategy for a weak side. Now, in contrast to that, this pusher syndrome is where someone actually pushes or leans towards the weaker side of the body. Now, you can see why this would be extremely limiting as far as overall balance in walking if someone constantly pushes their body over to the weaker side of the body. Now, this isn't extremely common. In the literature, it says anywhere from 5 to 20% have reported cases of pusher syndrome after a stroke. In my personal experience, I would say it's closer to the 5%. Now, as I say that, there probably is some bias on my part as far as maybe because the outcomes aren't as good for someone who has pusher syndrome, that maybe a lot of people with pusher syndrome don't actually make it to outpatient, but maybe go to a skilled nursing facility. So there is some potential for some bias in my personal experience, which is that it is much lower than that, probably closer to the 5% of people that have a stroke usually end up with this pusher syndrome. Today's video sponsor is the Allele 3X percussion massage gun. Now, I do get this question a lot. Should I use a percussion gun for my spasticity? And I would say it all depends. Some people, it definitely helps, but there's also others where I know for sure that it does make the spasticity worse. But where I think a massage gun can be extremely valuable is in that very, very early stage where a muscle is flaccid. Tapping and vibration helps to give sensory input to the brain. That is where a percussion type of tool can be such a valuable addition to your toolkit. And so this product I'm holding here is called the Allele 3X percussion massage gun. It is one of the more reasonably priced massage guns that are on Amazon. This model right here is extremely lightweight. It comes with 4 different attachments that you can put on the end. I really like the flat attachment. I find it to be the most tolerable. And it has this angled handle on it, which does make it easier to reach some of those hard to reach areas of your body. This gun is extremely lightweight, it's quiet, and it is pretty powerful. I would always start on the lowest setting, work your tolerance up to the higher and higher settings. But as usual, this company was generous enough to support this channel. So by clicking on the link, you can learn more about the product, but it also does support this channel. So thank you in advance for your support. To learn more about this product and to purchase it, click on the link in the description below. Now back to the video. But nonetheless, in my experience, it is extremely rare. People that usually develop pusher syndrome, as far as the literature goes, usually have had a hemorrhagic stroke, meaning a bleed in the thalamus. Now, it does happen also. Higher rates of it happen with people that have a stroke or, a blood clot in the thalamus, but within the thalamus, people that have damage within the thalamus, people that have a bleed in the thalamus usually are more likely to develop pusher syndrome. Okay, so now before we dive into kind of my strategy in helping someone who has pusher syndrome, and before we dive into, more importantly, if you're a caregiver, the good cues and the not so good cues to give to someone that has pusher strategy. Before we dive into all of that, because that is extremely important, let's talk about how this happens in the first place. Why would someone who intellectually knows that one side of their body is extremely weak push so hard to get onto that side of the body? And in fact, and we'll go into this when I get into the strategies, the more you try and straighten them out, the stronger they resist or push against you to get themselves onto the weaker side of the body. Now, in looking in the literature, and I did recently just research the literature and did find an article that is much more recent than some of the articles I've read in the past. It was actually something that was just done in 2023, and I will put that link in the description below if you want to read the entire article. But the main reasons why someone might push onto a weak side of their body, one is that there's a disconnect between where someone's body perceives vertical, meaning upright, and what the eyes see. So for example, if you tilted someone on an angle that has pusher syndrome and you ask them, are you vertical? They would say yes. So in the literature, if you tilt someone about 18 degrees in one of the studies, most of the people with pusher syndrome would say they're vertical. However, if you asked them, is this door that you're looking at in front of you, are those lines vertical? They would say, yes, absolutely. So there's a disconnect between what the visual information is, how that's being interpreted in the brain, and how the sensory information is being interpreted in the brain. And because of that disconnect, they feel that that's why someone might push to their weaker side. Now, clinically, the way that I could probably explain this scientific explanation is that if someone feels like vertical is actually at an angle, when you try and help someone and actually get them to vertical, they're going to feel like you're pushing them way over to the other side. And therefore, they're going to try and right themselves, regain vertical to where their body feels vertical, which is actually going to be tipped to the side. And that's what we see clinically. So scientists kind of have explained it. And that is kind of how I would describe it, what I see clinically, and that might be the explanation as to why that happens. The other potential explanation, or what the scientists theorize might cause this, is kind of like a bug in the vestibular system. Now, briefly and very simplified, the vestibular organ is in the inner ear, and it is hugely involved with maintaining balance. There are two main kind of systems or components of this vestibular organ. One is a series or a group of canals that are all at different angles. So they're circular canals, and they're all at different angles, and they're filled with beads. And when you tip in one direction, the beads will spin in one of these canals, all on different axes. When those beads spin in that canal, it stimulates a nerve. When that nerve is stimulated, it sends a signal to the brain that you're kind of tipped in one direction. And that's primarily because these canals all sit on different axes. That's one component of the vestibular system. And there's some that believe that there's something wrong with that interaction between that organ and how that information is communicated to the brain. There's another system within the vestibular, or very organ within the vestibular system, that actually senses gravity. So gravitational force. And now if you're a physicist, please forgive me. This is extremely simplified, but simplified. I'm just going to describe gravity. That is the force that goes directly towards the ground. Now it's much more in depth than that. But we have an organ in our brain or in our ear that senses that gravitational force. So, for example, if you're tilted, the vestibular organ would kind of sense that gravitational force has shifted, and that's excellent information for our brain to right ourselves. When you right yourself, that gravitational force shifts, and there's multiple systems in the body that send information about gravitational force to the brain, such as like sensory touch on our feet, like sensory receptors in our skin and in our joints, things like that. So the vestibular system is just one component of that. There's one component within the vestibular organ that is actually responsible or partly responsible for picking up that information as far as gravity. Now you can see how that information would be extremely valuable in maintaining an upright position. And then the other explanation or rationale that this is good information for you guys who are working with someone that has pusher syndrome, because if you understand kind of maybe some of the mechanisms that are contributing to it, you won't get so frustrated. So I know some of you really despise my lengthy explanations, but when you understand what's going on in someone's head, you won't get so frustrated that they're resisting you or that they're trying to fight you. It'll help you to really understand the person that you're working with and not get frustrated. So that is one of many reasons why I go into these explanations. But the other reason why someone might develop or might push towards the weaker side of the body is due to some sort of what we call extinction. So extinction can also sometimes be referred to as neglect, but extinction, sensory extinction, big picture, is just when the brain cannot receive multiple sensory inputs at the same time. So what it does is it basically excludes sensory information. So this can occur. So sensory information can be touch. So if someone excludes or neglects touch, meaning they can't feel when you touch them because their brain is excluding that information. It is not allowing that information into the areas of the brain that need to receive that information. This can also happen with gravitational extinction. So meaning that all the sensory organs that give that brain information about that gravitational force. Remember, this is critical. If someone tilts, that gravitational force changes. Those sensory systems will pick that up and send that information to the brain. Some believe that pusher syndrome is because the body is, or the brain is not receiving or not allowing that information regarding the gravitational force to get to the brain. And yes, I will say clinically, this makes a ton of sense to me. So if one side of your body, the uninvolved side, is experiencing the force of gravity, or that information's getting to the brain, just kind of think about this for a minute, and an entire half of the body is not feeling that that gravitation, those sensors are picking up any gravitational force, meaning that there's basically no force. That's the way I visualize this, is that like this side of your body is just floating into space somewhere, the involved side, like it just doesn't exist, right? Then you can see how that would be problematic, and someone might have a tendency, and again, I'm speculating here based on what I see, but to take the science and what I see clinically and explain it, I could see how someone's trying to restore that gravitational force, trying to restore, oh no, there's no information coming in. There's no sense of gravity on this side of my body. I've got to restore it. So they push onto that side. Now, that might be a stretch, but when I read research, I always try and read it and receive it through the lens of what I see clinically, and that would make sense to me. If someone doesn't sense any of those those receptors aren't sensing any of that gravitational information, you might push onto that side, like, I got to keep this side down, I guess, is kind of how I explain it. But that is what we see clinically. And then the other thing is just neglect in general, neglect to touch. And this will become important. Neglect when I get to the treatments, but extinction of any of the other sensors, touch, vibration, pressure, anything like that, there is a neglect, meaning none of that information is getting to the brain. So someone is just not aware that there's even a side over here. Because as I'm sitting here right now, I can feel my shirt pressing on my skin. When I put my hand down on a table, I can feel the table on my hand. I know there's an extremity that exists over here. Someone that has pusher syndrome does not feel that. So they literally do not feel that side of their body or that anything even exists over there. So that is going to become important when we get to some of what I would consider like kind of my like little formula for treating pusher syndrome. So long story short, that's what's going on inside the brain. Pusher syndrome is when someone pushes extremely hard to their weaker side. And I will say that the majority of people that have pusher syndrome, a lot of times, like I said earlier, their prognosis is not great. Like a lot of times they are confined to a wheelchair because it's just not safe. If someone's going to stand up and they're going to push onto their weaker side and that side is not able to hold them up or right them to straighten back out, that is extremely dangerous, that they're going to fall and potentially break an arm or a hip on that side of their body. Now, before I get into the treatments, I want to talk about one other thing, and that is, how do you help someone that has pusher syndrome? And I would say the last thing that you want to do, and this is even hard for me as a therapist because I want someone to be safe, the worst thing you can do is push someone back when they are falling. Because one, if they think they're vertical and now you push on them because they're not vertical and they're falling, they are going to resist you extremely hard. Not only that, they're going to resent you. So think resist and resent every time you want to push that person. And I have seen it clinically where someone has actually said, why are you pushing me over? Why are you trying to make me fall? That's when I have made the error of trying to push someone back because I was concerned about their safety, that they were going to fall. So that's always been a learning lesson for me. When someone responds with that comment, I know I am providing too much cueing to someone that has pusher syndrome. Why are you trying to make me fall? So when you touch someone, they are going to resist and potentially resent you because they think you are trying to make them fall over. So extremely, extremely important. So now what do you do with someone that has this if you can't do that? And that gets into the meat and potatoes of this video, which is actually, how do you approach someone and what's the best strategy to work with someone that has pusher syndrome to make them feel comfortable standing and walking, but more importantly, to make them safe and not fall. And for simplicity terms, I tried to come up with a way to help all of you remember this. And I came up with the 3 Ps. They stand for position, so always being worried about or thinking about the patient's position, progression, so skill progression, and proprioception. Now, I tried to stick with 3 P's, and so I did kind of throw in a technical word, but proprioception is just basically where our body is in space, how our brain knows where our body is in space, or how our brain perceives where our body is in space. So position, progression, and proprioception, and all 3 I think are the main things that should be taken into consideration when thinking about how to help someone if you're a caregiver, but if you're a therapist as well, probably like the main 3 categories that are most important to take into consideration when developing a treatment plan for someone that has pusher syndrome. So first, let's just talk about position. So first, let's talk about position. And the main reason that selecting the best position is so important, in my opinion, is trust. Whether you're a family member or a therapist, if you lose that trust with the person that is experiencing a different reality than your reality, it's going to make helping that person extremely challenging. Not only will they not be motivated to participate, but worst case scenario is that they think you are trying to hurt them or harm them. So if someone cannot stand without you having to manually hold them up, then it is a good idea to go down and sit. If someone cannot sit without you holding them up, then it is valuable to go down even further, meaning giving more stability, and go to laying down. So the place I like to start with everyone, regardless of where they're at, meaning that if I know someone can't stand, I'm probably not going to try it just so that I can see that they can't do it. I'm probably going to go err on the side of conservative and go more towards the lower end. So if sitting is questionable, then I will immediately just resort to laying down before I attempt sitting without any kind of support. So the place I like to start is laying down on the involved side. Now, involved side I have labeled with a piece of tape. The reason I like laying on the involved side is it gives that input. It gives that sense of gravity. It helps to give sensory input. The skin's getting a lot of sensory input. And you're just going to hang out there until someone feels comfortable and they're not really trying to push back and roll back onto their back. Now, if the shoulder is sore, you want to bring the shoulder forward and put something underneath their head and just let them hang out there. Position is all about maintaining the position until someone feels comfortable. All right, once someone feels comfortable laying down on their involved side, then we're going to attempt sitting without back support if at all possible. Now, if you have someone, and this is pretty common, that also pushes back, you might want to just put something behind them so that they feel safe, that if they lose their balance, it's not going to hurt, so they won't be afraid to sit back up again, but also so that you don't feel like you have to manually push them forward. So if you don't have anything behind them, just trust me on this, your instinct is going to be manually to push someone forward. Again, it comes back to that resistance. I don't really like that, so a lot of times I'll just put some safeties around someone so that if they did lose their balance, there's something right there to catch them, but at the same time, it's not touching them. So you do want them to work on sitting without back support. So just having something back there for safety. And then this is the involved side. And again, this comes back to this being very different than compensation. We're going to put something stable on the uninvolved side. I like something a little bit taller, like a chair. Remember what I mentioned, that someone will really push really hard onto that weaker side? It's very common in the arm. If the arm is anywhere where they can get leverage, they're going to push super hard. So by just putting the arm up and out to the side like this, sometimes even when they push, they're going to try and push and extend that arm. It's not going to push them over. So they can still do that, but it's not going to push them over. And then you're just going to work on leaning to the right. Now, trust me on this, if you're a caregiver, it's going to seem very foreign to you, but they are not going to like this position, and they're definitely not going to like leaning towards their stronger side. So again, position is all about finding the position that's challenging, but not too challenging that they resist it or push against it, and then just maintaining it until they get comfortable before you move on to the next position. So again, you're just going to sit, arms supported, safety on the, or something secure and stable on the strong side so that someone will feel safe to go over towards the strong side. Try not to sit next to them on this side. It's going to be extremely tempting to do that, but you're just kind of giving them a security on that side. And so there is more of a tendency that they're going to push to that side. But more importantly, you want to eliminate anything that would give them comfort on this side. So you sitting there is comfort on this side. You want to eliminate that so that it discourages them from wanting to get over there. So on the strong side, and you're just going to hold it. If they can do that, maybe even do a little bit of a shift. A lot of times the foot will shoot out, so sometimes just putting something in front of the feet will also help to minimize the amount of push that they get to that side, and just shift onto the strong side. Now, this position, you really want to spend a lot of time here for two reasons. One is to build that comfort shifting onto the stronger side, but two is also there's a motor component to this, and some of that has to do with just like the postural weakness, the muscles that are weak due to the damage in the brain, that they can't coordinate the muscles to actually do the weight shift. So just hanging out over here and maybe doing just a little bit of a shift, you're kind of helping them to relearn how to engage the right muscles at the right time to weight shift. And again, when you're doing this, don't try and make sense of it in your head, because it's not going to make sense. If I could give anyone any advice, whether you're a therapist or a caregiver, every time you try and make logical sense of what someone with pusher syndrome is doing, you're probably going to give the wrong cues. That's just my experience. So you just kind of have to trust that this is a very foreign concept that is going on inside of their head, and it does not match reality. And so try and just fight that urge to like rationalize why they're doing it and just stick to your plan. That's the best advice I can get. Get the plan and just stick to the plan. The only time you deviate from your plan is if you see a lot of resistance, you advanced the position too early, and you would want to go back down to the previous position. All right, now we're going to move on to standing. I am going to show a little bit of how to get someone to standing, although that's really going to be in the next section, which is going to be skill progression, where we're going to really break this down and how to help someone go sit to stand the best way where they're going to feel the most comfortable. But for the purposes of just getting to a standing position, there's only one thing I'm going to say, and that's to start on a very high chair. You're just setting that person up for success. The lower you start, the more you're going to struggle and feel like you have to pull them up to standing. And again, the more they're going to feel like you're trying to maybe throw them off balance or make them fall. So just get someone sitting on as high a surface, or your family member, get them sitting on as high a surface as possible. That's step one. And then you want a wall on the strong side. Again, completely different from how you would help someone that I talk a lot about on this channel who has a lot of compensatory patterns. They're leaning to their strong side, but in this case, we want a secure surface on the strong side so someone will lean into that side. Now you will notice I have some blocks down on the ground. The reason for that is that they like to kind of put their foot way out to the side. So if they feel like they can't move their body off to the side, what they try and do instead is move their base over. So if they can't move their upper body over because of the way that you have them set up, or because you're telling them to kind of keep their arm against the wall or something like that, instead of moving the upper body, they'll just move their feet over to get them back into their, what they think is vertical. So blocks help to kind of stop that foot and keep their body over their base of support. So once you have the blocks and you have everything set up, first step, well, we'll get into the progression next, but just get someone to standing. And again, this is position is all about just static, maintaining the position. Find the position that is challenging and just help someone to get into that position using tools and secure objects around them to make them feel safe. And you're just maintaining the position until they feel comfortable. The goal is that their reality will kind of change. So I usually give cues that, like, see, you're not falling, even though you feel like you're falling, you're not falling. And just kind of reinforcing to their brain that to kind of make the two line up or match up, that their perception is maybe not accurate and that they're actually not falling. Have them keep their eyes open. If they're really panicked, you're not accomplishing anything, and so go back to the previous position or the easier position, and you're just going to hold it. Okay, so that is the first P, and that is how to choose the right position, and then how to set someone up to help them maintain that position. Now that we've talked about position, let's talk about skill progression. Skill progression is extremely critical. If you do something that is too challenging, you're going to get immediate resistance and immediate resentment. And let me tell you, that is not fun. To have a patient that resents you because they're afraid of you or they think you're pushing them over, or resists you, again, because your reality and their reality differ, not a good combination. So this does require kind of a lengthy explanation, but I think this is better to do with a demonstration. So let's head back on over to the gym and work on the skill progression. All right, now we're moving on to skill progression, and it's really, really common for people to skip over like the rolling part of skill progression. But if you think about it, if you think about how a baby develops, they start with rolling. Rolling is the foundation of movement. Even myself, sometimes I kind of skip over that and I really want to get to sitting and standing. And I'm sure if you're a caregiver or a family member, it's no different, that you really just want someone to be able to transfer, maybe stand for you when you're pulling their pants up or helping them to the bathroom, things like that. But rolling is really important. So for rolling, it's important to roll, or to practice, I think most important to practice rolling towards the strong side. It does two things. One is that you can teach someone a little bit easier how to push with the leg that they feel like doesn't exist. So you really want to start retraining how to push with that leg. Remember, when they're falling to that side, you already know this, there's no activation in that leg. That leg is not responding at all. It's not pushing back into the ground, and they just continue to fall. So rolling onto the strong side can help teach someone to push with that leg. But in addition to that, rolling towards the strong side, you're kind of reteaching someone how to weight shift or move onto that strong side. So they've kind of lost that ability altogether. So for a variety of reasons, some of it is musculoskeletal, meaning that they just can't coordinate the muscles. Some of it's visual perceptual, which we've already talked a lot about. But getting someone to feel how it feels to kind of do any kind of movement towards that strong side is valuable. So starting on the back, this is the involved leg, and you're just going to work on pushing. They're just going to push and help them as much as they need it. You want to set someone up for success. If they really resist it, kind of put some blocks or something behind them, so even if they push back, they can only go so far. and then just kind of work it very, very slow so that they feel comfortable with that roll. All right, now we're going to work on sit to stand. So this is the next skill progression. Once someone can feel comfortable laying down and rolling onto that side and pushing a little bit with the weaker leg, and you've gone through the position component and you feel comfortable that someone feels comfortable sitting without falling to the weaker side or pushing backwards, then I would start working on sit to stand. Again, you want the safeties and everything onto the strong side. And the very first step is just forward weight shift. Even if you maybe just have to hang out there, but you're trying to start teaching someone how to shift their weight forward and either keep it in the middle, or even better, shifting it more onto the stronger leg, which is going to be able to offer them the most help when going sit to stand. If you go to lean forward and they immediately go to this side, or they just panic and they resist you, start to resist you and resent you, then you're moving too quickly, and go back to just working on sitting balance and then work on rolling. So the skill would be rolling, and the position that you would want to focus on is sitting in preparation for sit to stand. But then once they can weight shift forward and either keep their body in the middle or even slightly shift to the right, then you can do what I call like a little lift off. So you just do a little bottom lift. If they can't do that from a low surface, I would try it from a higher surface. And again, the first step is they have to be able to weight shift without their body shifting off and going off in this direction, and then just a little lift. This is a pretty low position to try and do this lift off from, so I do recommend that you do start on a higher surface once you start working on this lift off component of sit to stand. And so again, just a little lift off. All right, and then moving right along, once you feel like someone can do that, then you're going to kind of have them lean forward a little bit, and again, push up a little bit higher, this time trying to get their legs as straight as possible and holding that position. If they're trying to move their foot over to the side, try and find a way to kind of keep their foot from sliding over. Again, I like being kind of close to a wall. Again, you're just giving them a little bit more security on that side. And then again, you're just going to lift a little bit higher. Notice I'm still keeping the chest down. That lowers someone's center of gravity and will make them feel safer in an unsafe position to them. So keeping their center of gravity low is really, really valuable to build their confidence and to make them feel more secure and not try and resist you, less likely to resist you. There is going to be some resistance at every step in this process, but you're trying to find a compromise. So you want to challenge someone, but also not to the point where they just don't want to do anything with you, right? So especially if you're a caregiver or a family member, that can be really challenging if someone doesn't want to work with you. So again, set them up for success and make them feel safe, and then just lifting that bottom up. All right, now we're going to work on full sit to stand with ending with the chest up. This is a huge leap. So you'll notice I just automatically switch to a higher surface. When you first start to go sit to stand and your ending position, you want someone to be fully standing up, meaning they can already do that little partial sit to stand. You want to move to a higher surface, again, to set someone up for success. The foot setup is to have a block kind of between the wall and the foot, and then another block between the feet. Now, the reason for that is that I can't really explain why. It probably has to do with one of those reasons earlier that we talked about as far as mechanistically what's going on in someone's brain, but they will try and bring their feet together. As counterintuitive as that seems, they're trying to get back to their reality of where midline is. And so just by putting a block in between your feet, you're just kind of, their feet, you're just kind of discouraging that a little bit. And then everything else is the same. Forward lean. Because now they know that they're going to stand, there could be a very strong tendency to go back to pushing to the side, because now that fear is setting in and they're trying to gain control and regain where they think safety is, where their middle is. So if that's the case, then don't go straight to standing. Go back to all the progressions that we did from that sit to stand first on this higher surface. And then once you feel like they can lean forward and you feel confident that when they go to push with their legs, they're going to kind of try and stay closer to the wall, cue someone to try and keep their shoulder against the wall as much as possible and stand up. And then lean forward and back down. Now remember, if someone immediately pushes to that side, your reaction is going to be to push back, and it is not going to be good in the long run. So go back to just the seated forward lean and save the standing for another day. So they're not ready, okay? But then lean into the wall, push, cueing them the entire time to try and keep their shoulder in contact with the wall. If they're really panicked when they're doing that, try and encourage them to focus on what's around them, use visuals around them, see the wall is straight, you are lined up with the wall, that means you are straight, and just try and get their perception to match reality. Okay, so again, lean into the wall and push to stand. Down and back down. And then finally is the third P, which I'm terming proprioception. And this is like a whole separate category that I do think needs to be considered. How do you improve someone's overall proprioceptive awareness? Some tools that I like are a vibration plate. So again, just someone sitting with their feet on a vibration plate or standing with their feet on a vibration plate if they're at that level, I think is extremely valuable. You can even put someone's arm on a vibration plate. And again, that's just trying to get more sensory information up to the brain from the involved side. I also like a massage gun, same kind of premise. That also helps to kind of give sensory information or send more sensory information up to the brain, hopefully to minimize some of that neglect. Some strategies that don't require any tools that I utilize often, because again, they don't require any tools. When you're doing activities with someone, tapping, rubbing the arm, anything like that to also try and get more sensory information up to the brain, as well as approximation. So sometimes just if someone's laying down and they're working shoulder movement, I know this is about standing in balance, but shoulder movement, just a little downward pressure through the arm to kind of approximate, meaning put a little bit of pressure through a joint where you're bringing the arm bone kind of a little bit more into the socket. We call that approximation. So I find that to be extremely valuable to address this proprioception issue. And then the other thing, which is a minimal tool, but I use quite frequently and I talk about quite a bit on this channel, is deep pressure. So the air splints provide deep pressure. That's another sensory system that brings information to the brain. Deep pressure is also valuable information for the brain. So that's why I like the air splints, is getting that deep pressure sensation. And then some of the literature does talk about E-stem as a valuable tool. I'm a skeptic on the E-stem, and that's just because of how I've seen it used in big kind of factory therapy settings where someone just gets set up on E-stem and just sits in a corner for 30 minutes, which I think has zero value. Not only that, it's not a skilled intervention. So therapists that are billing for that, I think is just wrong. If you wanted my personal opinion, but it is talked about quite a bit in the literature that it can help for to activate or stimulate some of the muscles that can help someone to right themselves appropriately. But maybe that's a whole nother topic in how to use it and when to use it and where to place it would be an entire video in and of itself. But just know that there is a lot of evidence that suggests that that might be beneficial for someone that has pusher syndrome. But I hope you guys found this video helpful. If you did, and you're new to this channel and you like this kind of video, go ahead and hit that subscribe button and turn on that notification bell so that you'll get notified every time I upload new videos. If you want to get videos throughout the week, you can head on over to Instagram, where I post 1 to 2 videos every single week, just to keep your home exercise new and fresh and add a little variety. So I would love to see you guys over there. I enjoyed spending time with y'all today, and I'll see you in the next video. Have a good day.